I'm Adelina Comas Herrera, the director of the Global Observatory of Long-Term Care, and I'm delighted to welcome you to today's webinar from the Data Science Interest Group. I'll just tell you a bit about what the Global Observatory of Long-Term Care is, and then we'll hand over to hear from our speakers. So the Global Observatory of Long-Term Care is a knowledge exchange platform that has been set up with the aim of sharing cross-national learning to improve and strengthen care systems. We're part of the International Long-Term Care Policy Network, and basically the idea is that we want to identify key shared challenges, showcase how to address them, and we want to learn from research evidence and also facilitate collaborations. And this is open to everyone. It works by people's willingness to share their work and knowledge. So basically, you can publish your work through some of the GOLTC publications. We also have a blog if you have any new papers you want to let the world know about. And the real motor of the observatory are the interest groups that organize webinars and share also relevant publications and resources. And we're building up a database covering by now 660 experts on long-term care, all listed by country, topics, and methods, so you can find people working on similar areas as you. And we share publications on long-term care. We're growing again quite a database on that, and it's all tagged and organized, and you have all the recommended reading from the interest groups, as well as a database of research projects and videos of webinars. And we will be sharing this video after the webinar in about a week or two. And I'm delighted to say I work with my colleague Naz Salehki on this, and we're just very, very pleased to be here with you today. And before we go into today, I just want to let you know that we have a lot of exciting other webinars coming soon. We have a bit of a record this next 3 months, and we are covering topics as diverse as continence assessment, research on pain in long-term care. We also have webinars from interest groups more focused on methods. So we have on the 14th of October one from the quasi-experimental methods interest group looking at China's integrated care and the impact it's had. We've got the first webinar of the unmet needs interest group on the 22nd of October. 24th of October, we'll be looking at Brazil and South Africa, reflecting on home care provision from the South. We've got one on qualitative process tracing in health and social care research from the qualitative methods group. Again, we're going to look at pain management, and then we will have a shared webinar on the 10th of December between the data science interest group, who's hosting today, and the qualitative methods interest group. So I think you'll agree with me, this is a really exciting set of webinars. And now I'm very happy to not delay you anymore and hear about what we're going to do today from Sam from the data science interest group.
Hi, everyone. Welcome. My name is Sam Rickman. I'm the lead for the Data Science Interest Group, together with the other steering group members, June Song, Tommy Henderson Ray, and Sarthak Saluja. It's great to see so many new faces and names here, as well as some familiar ones. I'm just going to very quickly go over, I suppose, a couple of things about the group, and then we'll get to the webinar. So we have been going for a little bit more than 18 months now. This is our 5th webinar. And as Adelina mentioned, our 6th one is in December with the Qualitative Research Interest Group. We basically cover quite a wide array of things which will count as data science. If you have missed any, you can catch up, as Adelina mentioned, and people do. I'll put these links in the chat, although I've seen Naz has already put quite a lot in. So you don't need to copy these down. People do watch the videos on YouTube. I just checked today, and the one with the most views has 40,000 views, I think. Not one of ours, but we're third. Yes, as Adelina mentioned, you can sign up as an expert, and if you want to do that, that would be great. If people are interested in things like writing blogs or having any of your papers added to the literature on our reading lists on the website, please get in touch. or if you want to be a little bit less involved, but you still want to hear from us, you can join our mailing list. I'm hoping that between me and Naz, we're going to be able to get a poll question up now saying, do you want to join the mailing list? If you're already on the mailing list, you can ignore it, or you can say yes again if you're extra keen. There we go. If, of course, we are GDPR compliant, so if you say no and you're already on it, we'll remove you. So yes, those are the main ways to hear more. Now about today, so we're going to hear from Dr. Abeer Badawi, who is a researcher at York University and the Vector Institute, which is Canada's national hub for AI research. I think what's really exciting about this is that there's quite a bit of sort of research that uses fancy models and methods, which are quite cool, but they're often not that connected to the real world. But this is a real study that happened with a hospital, and it's asking a very useful, practical question, not just about detection of agitation in people with dementia, but also anticipation, which is kind of a necessary step for prevention. And so when we read this as the steering group, we were really excited because it really stands out as a paper. So it's great to have you here, Abeer, to talk about it. I should say that we are obviously a very cutting edge interest group. So when we invited Abeer, this was a preprint. It's now been published in JMIR Aging. The title is slightly different. So I will share a link to it in the chat as well, and it's also on the website. If you signed up, you probably would have seen it. I think that's it from me mostly. We'll hear from Abeer for about 20-25 minutes. And then that should give us a good chunk of time for discussion and questions, chaired by Tommy Henderson-Ray from NHS England. If you do have questions, if you feel very strongly about them, probably the best thing to do is to put them in the chat while Abeer is speaking. But of course, at the end, if you want to put your hand up, we'll probably have a mix of both, depending how many questions there are. All right, that's it from me. Over to you, Abeer. I'll stop sharing.
Thank you, Sam, for the introduction. I will share my screen. Please let me know if you can see my slides.
All good.
All good? Okay, great. Okay. Hello, everyone. My name is Abeer Badawi. I'm currently a postdoc at York University and a faculty affiliate member at Vector Institute in Canada. My work is basically a mix between health and AI. My background is in computer engineering, my PhD, but at the same time, I'm really interested in working with hospitals, like in real world settings, because I feel we have a lot of published papers related to AI and health, but they're all theories. There is nothing actually implemented in real world. And I feel there is a huge gap or communication between the people from the tech side and health. And with this gap, we're not able to actually implement anything in real world scenarios. So today I will discuss the AI for agitation, how we can predict behavioral distress in people with dementia. And this work was a collaboration with Ontario Tech University, where I got my PhD, and Ontario Shores Mental Health Science Hospital, and they're both in Toronto, Canada. I will start with the introduction, the motivation of our work and problem definition, and then literature review to know what other people did in this field, and then the main objective and the question of this research, what we propose as a solution, the results, and finally the conclusion and future. So what is dementia? Dementia is simply how we are knowing that there is a problem with the memory in the specific patients, and we have a problem with the communication skills, and we are actually losing the main skills you need for daily activities. 50 to 90% of people with dementia experience something called the neuropsychiatric symptoms, which simply affects the person to be able to engage in day-to-day life. Among the MPS, the major problem we currently have is something called the agitation and aggression behavior, which happens in the severe cases of dementia when people start to get really agitated, we can't control them, and in this scenario, usually they go to the long-term hospitals. The poor management of these symptoms can accelerate to a cognitive decline, worsen of the quality of life, and increase the accident rate. And this is for sure a huge problem to the family of that person and also in hospitals. So with numbers, in Canada, there is 78 million people with dementia by 2030, but it's going to be 139 by 2050. And in the population currently in 2019, there is 1 in 11 people having it above 65. In 2050, it's going to be 1 in 6 people. And specifically in North America and Europe, it's going to be 1 in 4 people. So the numbers are actually huge. Like if you can see the numbers here, if we're talking about how many, like the money we need to spend to treat people with dementia, we can't treat them, but at least take care of them. We're talking about 1.7 trillion US dollars by 2030 and 2.8 trillion by 2050. If we're comparing this with business, that we have Apple, Amazon, Walmart, dementia will actually exceed the number of the largest business in the world. These numbers are actually concerning a lot of people, especially in Canada. The government is having a lot of funds related to dementia care, dementia research, to make sure we know how to handle them, how to deal with it once they're especially in the long-term care. So, what is our motivation in this work? We care about that specific part, the nursing home or the long-term care. As we know with dementia, there's like simply steps, as we say. We start with something you can handle at home, and then you need more support, and then you need someone to live with them. And sometimes they can go to the adult day programs, but at the end, if it gets really severe, they go to the long-term care. And this is where we are focusing on this study specifically. This is an example what actually happens in hospital. For example, Ontario Shores Hospital, sometimes they get really agitated. They start hitting, kicking, screaming. They even get agitated with very simple things like switching the light. Someone is talking, someone new in the place. And they actually don't know how to handle it. In the scenario with Ontario Shores Hospital, they just have to stop it. They give them some kind of medication, and that's it. This is the only way they handle these scenarios. So what is the problem definition here? We want to detect agitation behavior in people with dementia. And by detecting, I'm saying that we want to know when it's going to happen. We want to know how to predict it to be able to prevent it in a better way. So people with dementia still suffer from agitation accident, and people around them, nurses, anyone working with them, this is something that happens daily in these long-term hospitals. So what is the actual problem now? The reports are the only records we have for the agitation. So what happens that the nurse will have a paper and pen and write down what actually is happening. The problem here that sometimes it's biased, missed, and inaccurate because the nurses don't actually record everything exactly as it happened, the start time, the end time. They don't even know the trigger, why this happens. So we need to find a way to identify agitation and pre-agitation events exact time, and we want to do that using the wearable sensors and AI to detect agitation and find a solution to this problem. So the literature review, just noting that this is for anything before 2022, I think, just because this is when we did our research. And what we found, any publications after 2015, we wanted to see if it's in a real world setting, the number of patients, the study length, if they have dementia agitation, the kind of sensor they used, and the contribution. And we only found 14 papers. And the main research gap we found from the literature review that it's not collected from actual patient, unfortunately, because as we all know, it's not really easy to get approval from hospitals. So all the data is collected from the literature reviews coming from a home care, for example, or some kind of a data set that they created, like someone is pretending that they are having an episode of agitation to collect the data set. We have a lack of machine learning and feature extraction investigation, how it works and how we can extract the features. There was a significant gap in how we have a labeled dataset. We couldn't find any labeled dataset, and labeled dataset meaning that I have a dataset that's labeled, this is agitation, this is not agitation, so we can train it using our models. And there was also a gap with the agitation and pre-agitation detection, and we fall short in finding the exact time of agitation, which is the main idea of this work, how I can actually find when the agitation started and why it started. So what is the solutions we are proposing for all the research gap we found? We wanted to have a dataset collected from real patients. We wanted to have top available wearable sensor. That's why we used Embrace Plus to collect the dataset and collect all the sensors from the patients. We wanted to investigate the machine learning and feature techniques in depth. We wanted to know which one is suitable for this specific type of data. And we wanted to find the exact agitation and pre-agitation time using cameras and wristband. So to clarify the research questions that we want to answer now, number one is how well does AI detection system work in these settings with agitation and people with dementia? What's the limitations of the existing current sensor tech for production agitation and how our system will overcome them? How we can use wearable sensors as a multi-model system, which means using the wearable sensors with cameras to identify agitation and pre-agitation in hospitals. So now I will discuss the proposed system in clinical settings. This was only a proof of concept, if this is actually going to work and how we can implement everything in the hospital. So to start, we needed to have everything related to the ethical approval, starting with the approval from Ontario and Ontario Tech University. This took us around 4 years to get the approval because, and this is again something we will discuss with the limitation, this is not something easy to do. It's really nice to say it in theory, but when you apply it, it wasn't easy to have wearable sensors on people with dementia, to have cameras in a hospital to record everything. It wasn't very easy to apply because there's a lot of steps you have to go through, I will discuss, and also a lot of approvals, and you need to make sure everyone in the hospital are comfortable enough with the cameras, the wearable sensor, and writing the notes and everything. The second thing, to get the consent. This scenario is usually easy in the health field when you're getting the consent from the patient, but in our case, we can't get it from the patient, so we had to get it from the family member, for example, or the decision maker. And again, that wasn't very easy because imagine calling the son, the daughter, telling them we want to collect information from your dad or mom and put cameras. That wasn't something that they really liked. Only the people who actually understood what we're doing here and we're actually trying to help them, they agreed. But I will say majority of them didn't agree. They didn't like the idea. The privacy measures, again, that took some time because proposing the video, we need to make sure that we have to blur all the faces. This is something we do with deep learning, meaning that the cameras will not record any faces. We're blurring all the faces. And we're even not having the body image. We're having something called the skeletal, which means that we're only having measures of like lines, basically. There is nothing related to the body image, how the body is looking. It's only the dimensions and how the body is moving. And lastly, the security and making sure everything is stored. We had a specific CPU that stored everything, and only one doctor were allowed to actually check the cameras. So we didn't have access to the cameras. There were only one doctor who would check the exact agitation time and let us know the start and end time. And that's it. We couldn't see anything. And after that, we would delete all the records. This is an example of the dataset we're collecting from our unit. So the GDU unit, for example, collect all the events that happened. That was the manual part, which people would actually just write down what's happening. And you can see here, we only care about the first type of incident, which is the aggressive behavior. Sample of the aggressive behavior we got is hitting, kicking, yelling, shouting, pushing, grabbing, for example. And from these types, we concluded why we need the cameras, because the camera will help us detect the movement. At the same time, the wearable sensor will help us detect the heart rate, the skin temperature, for example, so we can cover everything we need to actually detect the agitation events. So the study design, we started with recruiting 10 participants, 60 years older, and they met all the criteria for the specific dementia, the severe dementia. And we got the consent from that 10 participants, and then we installed the cameras. There was no audio in the cameras, only the videos. All the faces were blurred, and we only had the skeletal points extracted, not the actual images. And then the patient will wear the Embrace Plus for 24 to 72 hours on 3 different occasions over 6 weeks. We wanted to make sure we capture as much agitation events as possible. And the staff also recorded the events, so we recruited 2 people to just be there in the unit all day. And whenever any agitation event happened, they will write it down. And this is again just to make sure we actually capture the exact time of agitation. So this is the proposed system. I will explain it one by one, but at the end, what was the main goal? We want to confirm the exact agitation event. Step number 1 is the Embrace Plus. The patient will wear it. At the same time, Embrace Plus got their own mobile app. And also to note here, we created our own mobile app because we were worried about the privacy, because if you're using the company mobile app, that means you're sharing the information with them. So we created our own app just to make sure the privacy is met. And then we have the cloud, the back end, the dashboard to send all the data set collected whenever they're wearing the wearable sensor. And then we got our cameras, and with the cameras, we will do the pre-processing, the deep learning classifier, save everything to the cloud, and then we would detect any abnormal behavior, any physical aggression, any motor activities, any verbal aggression, and we would capture that aggression, and then we record the incident, and then we check the records. As I mentioned, only the doctor will check it, and would just send us the exact start and end time of the agitation event so we can add it to our dataset. And lastly, to make sure we got the exact time, we also added the nurse notes. We hired a specific nurse just to be there. We give them a specific form to fill. Whenever any agitation event happened, they will write down the exact event, what happened, how it started, if they have any extra note to add to our dataset. So let's talk specifically about Embrace Plus because the results will be mainly about this. This part is a little bit technical, but I will just explain it as simple as possible, just for everyone to know how the process works, how we actually can get to our final dataset. So we use the Embrace Plus. This is the world's most advanced smartwatch for health monitoring. And we start with the raw dataset. We got the accelerometer, meaning that it measures any movement of the body. We got the heart rate. We know if the heart rate is up or down, the body temperature, and something called the EDA. And the EDA will test the skin temperature to make sure if, for example, they are nervous, they are angry, the EDA will change. So we know there is a change in the skin temperature, which means this is not the normal behavior. They are going through, for example, some kind of a phase. And then with the pre-processing, you have to clean all the signals. We have to filter the signals and do something called sliding windows, meaning I need to slide the window to make sure I extract the features related to the raw dataset. For the features, we extract statistical time domain, frequency domain, and time frequency domain. Why this is important? Because with the raw dataset, it's not enough to capture the agitation events. So think about it as I have the accelerometer, the body movement XYZ, but I can't get anything out of it. The features works in a way that it extracts these for you. Some of the features, for example, is the minimum, maximum, the mean. So instead of just reading the raw dataset, you read features that shows something significant that you can conclude something out of it. For example, with the heart rate, I will go with the minimum and maximum features. Why? Because with the minimum and maximum, you can know what's the normal for that person and what's high for that person. And with that, we can tell, okay, when the heart rate is high, that means something is happening currently, and we know, for example, maybe it's an agitation event. Then the classification, we use the multi-layer perception, and we have the random forest, the X-trees, XGBoost. They are machine learning models. And again, in simple terms, how they work, the classification works as the human, but it does it in a better way. So think about the human reading the features and saying, okay, I can see something here. This is called a high rate. This is called a heart rate higher. the accelerometer here means there's a movement. This is basically what the classification does. The classification tells me if there is something abnormal happening with my data set. Adding to that, we also had the digital biomarkers. This was only in Embrace Plus, the latest version they had. So we got this one because they also added something called digital biomarkers, which is basically they're doing the work for you. They're calculating everything and giving you the final output. So they calculate the body position, the activity class, the step counts, activity counts, the sleep detection. They do it all for you and just presenting the results. Why it's good to have both? Because when you have the raw data, your own results, you can customize it the way you want. Like in our case, we cared about specific features. Or you can go with the digital biomarkers, and that saves a lot of time, especially with people that don't have AI background. You can just use the digital biomarkers to get the same results. And lastly, we get the agitation and the pre-agitation detection. And to clarify how we did that, think about 10 hours of data set. I would label anything in this data set that there is nothing happening as 0, and 0 will be normal. If there is any agitation event, I will label it as 1. If there is any pre-agitation event, I will label it as 2. So my data set at the end is labeled with 3 labels: normal, agitation, pre-agitation. And how we got these labels? We got them from the figure I just showed you, that with the wearable sensor, with the cameras, with the nurse notes, they tell us the exact time of agitation, and then we label them in our data set. Something more to add here is the real-time architecture, the part I mentioned that we created our own mobile app. Again, this is very technical. I'm not going to discuss it in details, but I'm just saying why we need it. At a point, if you don't want to use another mobile app because of the privacy, you will need to create your own. Here, you need something called IoT, Internet of Things, meaning that you know how to work in real time. So step number 1, you can collect any information from any wearable sensor, create your own mobile app to take this data, and then something called things board, meaning that I want to send the data in real world, and then we use Kafka to send it to our database. And then this is where we're talking the data analytics and prediction. This is what we're proposing actually, but this system works in real time. Why will you will need the system? You will need it in the last stage. If you actually build the system, it's working amazing. Now you want it to work in real time, meaning if there is any agitation event happening in real time, you're able to detect. You want to send a message, for example, to the healthcare provider, telling them, by the way, we think there is an agitation event happening soon. So to do that in real time, you need system similar to this that makes everything work in real time, online, not offline. And then for the video system, what we did here, that we have the privacy part. We had 3 cameras in that one unit, and we had all the faces blurred with open pose. We capture everything in a skeletal movement instead of the raw video. And this is an example of a skeletal movement. As you can see, you don't see the body, you can see only the lines. Why I care about the lines? Because this is how I can actually measure the distance between the hands, the legs. And when I do that, I can see if we're moving faster, meaning that maybe there's something happening with the patient, compared to, for example, they're just sitting. That means nothing is moving, there is nothing to measure. So there is no extra movement at the moment. And for the offline phase, we extracted 39 features. We used 2 deep learning models called GRU and LSTM, any deep learning model that are able to extract features. And with the real-time phase, we use the live videos to detect agitation. We save every event and 5 minutes before and after. Why this is critical? Because we don't actually know what happens before and after the agitation event. So we would capture 5 minutes before and after, so the doctor can see the video and actually notice what was the cause of the agitation, and also what happened during the agitation and what happens after the agitation. And to have the continuous improvement, the doctor will let us know the exact time. We would save that, retrain our model, and with the retraining, the model will be able to learn more. Again, think about it as the humans, how we learn. When you give the model more information, the model is able to predict everything more correctly. So if the doctor give me more exact time of the agitation events, the model will be able to learn what actually happens during the event and predict it in the future. So the results, we'll start with the participant. We had 5 females and 5 males, and we had approximate, I will say 60 above age, and the time collected we have around from 35 hours up to 99 hours. So that was collected starting from August 2023 to September 2024. Whenever we have new participant, we will add it. This process again wasn't easy because starting with getting the approval from the decision maker, the patient wearing the wearable sensor, collecting the data, I will say some cases that we're not able to continue. For example, the patient, they were able to take off the wristband, so we were not able to collect anything. They didn't like the wristband. They will get really agitated when they are wearing it. Again, we will stop the study. In some cases, they didn't have any agitation events. Also, other cases we faced that at the beginning, the patients that admitted to the unit knowing that they have agitation events wouldn't have any episodes for weeks, and we didn't know why. And then we realized that whenever they are admitted to the unit, there is a protocol to give them some kind of medicines that calm them down. So when they are admitted, they're actually never going to have any agitation events because of the medication. And that's why we were not able to detect anything. So again, we had to update our RAB, the research approval, that we want to make sure who's ever admitted, they shouldn't take the medication the first week, to make sure we are detecting something before they go with the medication. Okay. So the results, we will focus on the accuracy, the AUC, and the recall. Why we care about these measures? The accuracy, it's basically predicting if the model is able to know the difference between the agitation and non-agitation events. So if you can see the first figure on the left from the 4 models we used, it's clear that the model is having good results above 0.8, which is 80%, from average of 10 and all general model. This is a very interesting point to discuss, the general model and personalized model. In my opinion, I prefer the personalized model. Why? Because I feel with dementia, it's not the same with everyone. So if someone, when they get agitated, one person will start kicking, moving hands and legs. Someone else will only have very high heart rate. So we can't have them both in the same data set and measure them all together. So with the general model, the one with blue, we can see that it's having good results, but this is only because we have 10 participants. In my opinion, if we have more, let's say 100, 200, the results will not be good at all because now we're mixing everything together. Why I encourage using the personalized model? Because we did notice that it's not the same with all the participants. The mean features that we found for each participant were different. Some of them, the features that classify agitation were accelerometer, others heart rate, others the EDA. So I would always recommend using personalized because at the end, if you're able to build a personalized model for a specific patient to predict agitation for that patient, this is the ultimate goal of this work. So the second figure is the AUC, and here it measures how well the model separates between the two classes. So let's say if I have a threshold and I want to make sure, does the model know what's the difference between agitation and non-agitation? We use the AUC. And also we can see we have good results, better for the personalized than the general model. And lastly, the recall. For the recall, we can see also we're having good results, but not for the random forest, especially for the general models. For the personalized, it's still good. What is the conclusion of this figure is that yes, wearable sensors and machine learning can predict agitation event. This is clear. And also we will clarify that using personalized model is better than the general models. An example why it's a good idea to use the personalized model, this is a random features from participant 1, 2, and 3, and specifically for agitation event. If you can see the top important features to classify agitation for participant 1 was the tonic, which means that we're collecting things related to one of the sensors. The second one was the accelerometer energy, and the third participant was the temperature, which clarify the point that it's not the same for all participants. We need to investigate the specific features for each participant to know the behavior of the agitation event to be able to detect it and predict it. Something else we noticed that we wanted to investigate in our study is the pre-agitation event. Does anything happen before the actual event? And this is something that we did manually for now because we actually wanted to observe what's happening. And as you can see in the figure, this is the pre-agitation and this is the exact label. And we can clearly notice that, for example, the heart rate, the activity class, the count is changing before the actual event. So if you can see on the left here, time 36:38, it was still, and then they start walking in the middle and then walking. The same with the counts, it was 0 and then up until it reached 150 during the pre-agitation and the agitation event. The same with the pulse rate, it was around 60, 70, 80, and above 80 before the agitation event and during the agitation event, and then back down. So here we can see clearly with specific patients, if we can know what they do exactly when they get agitated, we will know how to detect agitation and also the pre-agitation. So we will say that a specific movement for a specific patient may be a prediction with a pre-agitation. Some questions we will get that, okay, but this can be very general. That means if you're having the prediction monitor, it's going to be peeping all day. Like he's walking, he's walking, he's walking. I agree with that. But I will say what we saw with the unit, they don't do these events normally. Like if someone is walking in a specific movement, this only happened before the agitation event. And even if we have something called a false positive, what does that mean? It means that you detected something and it was wrong. Let's say I told you, by the way, there is an agitation event happening and it didn't happen. We will prefer that than actually not predicting the event. So let's say I told you there's an agitation, nothing happened, it's okay. But if one of them actually happened, you're able to prevent it, and this is the goal we want. So for now, yes, maybe this is not something that we can say, okay, I'm sure 100% this is going to be agitation. But if I'm sure 90%, 80%, this is still good because we can be prepared to make sure to have the best care to the patient before they actually get to the agitation event. And from the notes we got from the nurses, actually we can prevent it from happening. Like we don't have to wait until they start screaming or hitting someone. We can prevent that before happening, and then that's it. They don't have to go with the actual incident. They don't have to go with the medication to calm them down. This is also an example of the real-time performance evaluation. This is the app we created. The app is connected to the Empress Plus, collecting everything in real time. And the dashboard, this is what the doctor will see. They can see everything in real time. So they can monitor the patient, can see the temperature, accelerometer, heart rate, and if anything changing, anything the doctor can see abnormal, they will let us know, for example, the nurse, that there is something abnormal happening with the patient. In real time, as you can see, this is the portal that the end should be sending a message. So as you can see here, we can see the results in 3.5 seconds. So let's say this portal will give you a threshold. If the temperature is higher than X, then give me a message saying there is something with this patient. And we can know everything only from the wearable sensor. We don't need the cameras anymore. So if you know the specific threshold for each patient, it's going to be much easier to monitor them and know when there is any expected agitation event happening. With the video results, the last results we're going to have today, the performance with the LSTM and GRU models, we also have really good results with the accuracy and AUC. We see that the GRU slightly getting higher results, but it takes double the time to generate the results. So we would recommend going with LSTM if you want to save time. And we also noticed that we don't need much features, only 39 features with the body movement. They were enough to actually detect agitation event. So for real-time scenarios, go with the LSTM, but go with the GRU if you care about the high accuracy. Why we care about the real-time? Again, if you have a camera in the unit and you want to detect in real-time any agitation events happening, we care about the time. We care about how fast I can do that. So if you're going with less features, less time, this is the best scenario if you are having a camera in your unit detecting in real time any agitation or pre-agitation events. So the summary of the work, starting with the agitation detection, we did investigate the AI and features in depth. We recommend the personalized model, not the general model. We have a state-of-the-art results up to this date that works in real-world scenarios. And for the exact time of agitation, the camera, the nurse's wristband, I will always say is the best combination to start with. Later on, you can drop the nurses, the cameras, keep only the wristbands. Only once you have enough data set to train your model on. We were able to detect the time of agitation and pre-agitation, and we got the RAB approval of our project. For the real time, we built our real-time production system. We did test it in the hospital, but not in real time. We just tested on a sample because testing it in real time means, again, you're done with the project, you have enough participant, enough data set to conclude your results. And for the video system, it does qualify with all the privacy analysis available nowadays. We did use deep learning models to be able to extract agitation and pre-agitation events, and it captures the event. It was clear for the doctor when the event started and if the model is able to know when the agitation event started, at least from the cameras. So our conclusion and future work. So to advance in dementia care, we did develop a multimodal system to predict agitation and pre-agitation. We used wearable sensor, the Embrace Plus, and we also used the video. They both got good results, enough to use them currently. We also had the early prediction, and we would say approximately 5 minutes before the actual event, you're able to predict agitation. So more than 5 minutes, I will say 2 to 5 to be honest, but 5 was enough to see a change in the signals, to see that something is happening soon. And for future potential, I will say this research is just the start. I feel like more hospitals can implement the system, especially if they have more patients, are able to go faster with the RAB process. It's going to be way better. The ultimate goal here will be that you have enough participants. We're talking about 50 to 100. If you have a data set like this, I will say this data set will be enough to be able to build a full system, personalized system for all the cases and scenarios we can have with the agitation and pre-agitation. So what is the future work here? The data collection from Ontario shares. They're currently recruiting more participants. We want more than 10. The real video system, as we said, we want to implement it in real world. This is only going to happen after we have enough participants to retrain our models. And the life log system, that was an idea we had. We were hoping to implement it, but as I mentioned, it already took a lot of time for the RAB. We didn't have time for the life log. But this idea here that we wanted to have a therapy system instead of giving them medication to calm them down. So the therapy system, which a lot of people investigated, that you would get some memories from that personal information for that participant, and we would play some music they like, show them pictures for their family member or videos, or even having a robot to help them calm down. So why would this work? Because if you're not able to detect agitation, sometimes it's too late to provide any solution. But if we're prepared and we know when the agitation is happening, we can also be prepared with the therapy system that makes sure we calm them down in a way that it's relaxing for them, make sure they don't get agitated again, and control the output of the scenario that's happening with that agitation event. And lastly, the limitation of this work, as I discussed, but just to highlight it, if you're planning to do something similar to this work, the main problem you will face is, number one, the recruitment, the RAB approval. It wasn't easy. We got a lot of problems related to the nurses' approval, the hospital approval, even nurses understanding our work. We had to do a lot of seminars, presentations to explain to them what we're doing, how it's going to work, how it's going to affect the work they're doing, how we're helping them actually to prevent any agitation events. The labeling of the data set, it wasn't easy. As I mentioned, you have to manually do it from the nurse's notes, from the cameras, from the wearable sensor, at least at the beginning, because once you have a valid data set, it's much easier to verify later on. But in the first phase, you need to do it manually. The video collection, again, installing them, the nature of the analysis, the storage of the video, you need to have enough space to store everything. Make sure it's in the right place in the hospital to collect the data set. You may need more than one camera, more than one unit to make sure you're not missing any agitation events. And lastly, the consent. This is something I think we should improve. The decision makers, the family members didn't understand well what we're doing. We need to work more on having a clear, I will say, maybe presentation, PDF, something to explain what we're doing, how we're helping them. Because at the end, if you told any family member we're recording your father or mother, we're collecting information, they don't like the idea. They don't like why you're doing this. They're already not feeling good about their family member being in a place like this. So adding to that, they're recording them, they have to wear a wearable sensor. That's something you need to explain in a good way to make sure they like the idea. And thank you. And if you have any questions, please let me know.
Thank you, Abeer. That was fascinating. And I'm going to watch the recording again because your presentation was so rich in detail. I have lots of questions, but I'm not going to be selfish. Sam was very quick with his first question. So if I can go chronologically in the chat, and then if people have any questions and they want to stick their hand up as well, then that would be great. So Sam's first question was around, and I picked up on it as well, the sort of the labeling concept of agitation, because it's quite distinct. So the video we saw, I think we saw shouting and that sense of restlessness, and so how do you decide what's in and what's out, and how do you label what you label, and that in that way?
Okay, that's a good question actually. That was like a whole conversation with the doctors, but I think we decided to label it agitation once the actual aggressive behavior start. So if we're talking about shouting, screaming, hitting, moving hands, legs, this is when we define it as the start of the agitation. Because the pre-agitation, it was tricky because, as you said, sometimes they would move their hands and legs, but they're still sitting. They didn't move, but then they stand up and start screaming, for example. So we classified anything related to movement, shouting, screaming, as I showed in the figure, like what we labeled as aggressive behavior from the hospital. This was our label to start the agitation. Any 5 minutes before that, we label it as pre-agitation.
Understand. Thank you. And then Rebecca's put in a question which is linked to one of the questions I had, which is a bit around infrastructure, really. So how does the physiological collection and the connectivity and signal quality connect with what you're doing? So does the participant need to have phone connected to wearables near them at all times? And by extension, actually, let's go with that question first and then follow up after that.
Okay, so yeah, that's a good question. I think we had this problem with Empatica E4, the first version. We need to have the phone in the same area, I think, just to connect with Bluetooth. But with the Embrace Plus, I think the range got more, I think. We didn't have a problem with that. I think we only had the phones in the same area around them, and that's it. But the main collection from our end was from the background cloud, like from our computer. So all the data set collected was stored in the computer. By the end of the day, we're able to see, let's say, from 8 a.m. to 8 p.m. stored in that specific CPU, and that was the data we used at the end.
Okay. So open invite to colleagues on the call. If you've got questions for Abeer, now is a great chance to ask those questions whilst people are ruminating on that and thinking about what they want to ask. Marta, I'll come to that in a second. So in the UK, for the equivalent of what you're talking about, a lot of what would be delivered would either be in a residential care home or a nursing home as opposed to in a hospital. And therefore, lots of decisions would need to be made equitable to some of the things that you've articulated there. So I'd just be interested to know what you think would need to happen for this project to be scalable. What do you need in your toolbox for this to be pulled off outside of the hospital setting that you've articulated today?
I think the hospital settings is the worst case scenario. If you're going to home care, like actually we wanted to go with the home care. Everything is way easier with the home care. because with the regulations and everything. So with the hospital, I will say that's the extreme scenario with the approvals and everything you need. With the home care, it's much easier because it's easier to handle with the cameras, with the wristbands, and you can even easily contact the family members before they have their like family member in the home care, because at the end we will have it in a way that it's more of a product, like okay, having your family member here, I will offer you a detection of their case. I will let you know when they get agitation events, and I will help you to take care of them. So it's easier to sell the idea. The problem with the hospital that at the end you have a huge protocol you have to follow. You have to make sure everyone on the same page. You're dealing with different people, different positions, different background, and you have to explain your work for everyone. So this was the hardest part with the hospital. But in my opinion, I think this system actually fits more the home care because it's easier to handle, especially if they're in a room. We even wanted to test this at home. Like for example, if you're taking care of family member at home, if you're building the system, customizing it to that specific patient, it's much easier because you're recording them. You want to see the records. Actually, you want to see what they're doing when they get agitated, and you need to have the wearable sensor. You can use it at home. We at the end we give them the results. Like, okay, we will tell you that this is what happens when they get agitated, what happens before the pre-agitation, and even at the point we need to know what is the triggers. Like we noticed from the cameras that the trigger is lighting. The trigger is, for example, the kind of food they ate. So if we're talking about a smaller community, smaller settings, I think it will be much easier to implement the system.
And in some ways, I think the question that Marta had put in the chat is some way to that. So the difference between what was there a difference between the results in, say, a hospital and care homes, presuming that, and I think it's fair to presume that care homes and nursing homes are more centered on the person because that's often their home, they're a resident, that's where they live. But on the other hand, staff may not be as qualified. I mean, they may be, they may not. But would you sense, what would your view of that be?
I think they're similar because when we were like having a collaboration with the hospital, we did check different home cares. They all have the same setting. What you care about that they have a space that they all sit together. This is where the agitation events happen. They usually doesn't happen in the bedroom, for example. They always happen in the main area all the patients are in with the nurses. So if you have that specific place, that's all what you need to have the cameras to predict agitation from the patients, to customize the model and be able to predict the agitation.
Okay. I hope that answers your question, Marta. Thank you for that a bit. Question. Oh yeah, June, it's a really good question. If the patient has heart disease, for example, determining the heart rate alone would be difficult to determine the agitation event. Do you have any plans to control this aspect in the future study? Good question.
That's actually a great question. That's why I was discussing why I think personalized model is a good idea. So let me give you an example. Let's say my heart rate, for example, the normal heart rate is 70, but your heart rate, the normal is 90, for example, okay? The model, if it's personalized, will treat me as the normal is 70 and abnormal is 90. In your case, the normal will be 90, abnormal will be 110, for example. So in that case, when you customize the model will learn your specific heart rate, and then from that, you can tell what's normal and what's abnormal. So let's say we're putting thresholds. I will say 70 is normal, 90, maybe there is agitation event above 110. We're having a problem here. There is something happening. But as I mentioned with the alarm, what we want to do is have an alarm for anything above 90, because with the alarm, it's very easy to check on the patient if you know something is happening. If you at least know, because in many cases, we don't know. It's too late when we start to notice something is happening. Let's say a patient is sitting there and they start to get nervous. The heart rate is getting higher. The temperature is getting higher. The nurse will only notice that there is something wrong with that patient only when they start screaming or moving or shouting or hitting someone, even though we know the signs 5 minutes before. So when you have that kind of alarm, you would know something is happening specifically with that patient. But to answer the question, if they normally have a high temperature, this is going to be the norm. This is not going to be the alarm for me. The alarm will be anything above the normal or below the normal, and the normal is specified for a specific case, not generalized for everyone.
Okay, thank you. Two more questions in the chat. Conscious we've got 5 minutes. So a question from Ruth. So how does the model take into account external causes of agitation? For example, quality of care and the environment.
So that's something that we wanted to label. That's like in future work, we wanted to label something called the triggers. So we actually wanted to know why that happened. So this is basically the question you're asking, that what if it's not about him? Something else is triggering him. So if we label the triggers for each patient and you avoid them, that's basically the solution. But as you said, if it's something coming from the outside, this is something we can only detect using the cameras. That's why, as I mentioned, the camera is like really important at the beginning to know what's actually happening. So let's say I'm recruiting a patient. At the beginning, for the first week, we need the cameras to know what's actually happening around them to detect agitation, pre-agitation. And as you mentioned, maybe it's not about them, maybe it's about the environment. So one of the example, they had a huge problem with the lights. Whenever someone turned the light on, they would get agitated. Others will get agitated just because they saw someone new in the place, a new patient, a new nurse. They will start screaming, shouting. So at this point, only if you have the cameras, you would know what happened exactly to start the agitation.
Mm-hmm.
So with the cameras, if only the doctor is seeing what's happening, again, keeping the privacy at the beginning, I will say this is essential to make sure you know the reason, because we don't want to build assumption that, oh, this patient is getting a lot of agitation events, even though we can solve the problem with the environment, not about the patient. So it's more about we want to see what's happening around them, and then from that we can conclude the main triggers for that specific patient.
Okay, thank you. Question from Jackie. Oh, my screen's moving. If you have a monitoring system using sensors and voice to speak to the person with dementia who lives alone, what would you need it to monitor to raise an alert? Example, speech or reminder adherence?
Okay, so just to make sure like I understand the question, we're talking about if you want to use the voice as as a solution.
Yes, that's my interpretation. Yes.
Okay, so I don't think we tried the voice yet, but I think what you're saying is similar to what we want to present here. If you can see the life log here, this is the therapy system we wanted to present, which is having a robot talking to them, or a video. We show them videos, pictures, or music, something from their memories, from their personal data that make sure to calm them down. But at the end, I don't feel this is going to work much during the agitation event, because imagine they're agitated, they are so overwhelmed, and you get them a robot to talk with them, or get them some kind of recorded voice. So during the agitation, the main protocol they do in the hospitals, that they want to calm them down, make sure they don't harm anyone else, and give them medications to calm them down. What we're focusing on, how we can prevent it before it gets really extreme.
Mm-hmm.
With the therapy process, it will work, but this is, I think, something that will work to handle the agitation event that doesn't get really extreme. But I will say definitely it may work. In our case, we just didn't have the audio with the cameras because, again, it wasn't the focus of our work. You can see here, this is the microphone for the future work, but we didn't use the speech recognition in our work, because at the end, the nurses had a problem with the camera and also with the speech. Like, we're recording too much and they didn't like that. So we only focused on the camera because we felt from the camera you can see what's happening. But with the microphone and speech, yes, I agree, this is something it can help us. But if it's only speech, it's not something that will help you with the agitation detection, because not many patients talk or say that they're getting agitated. Without the camera, you can't actually know what's happening in that specific time.
Mm-hmm. Really conscious of time, but this is a really great question from Tim, and I just wanted to squeeze it in because I'm unmuted, so I'm going to ask it anyway. It's a really good point, actually. So, good human understanding and observation, you can understand when someone is upset and potentially why before they start to hit out. So are we potentially creating a world where we're using technology as a substitute for care rather than supporting it?
That's a good question. So I think this is like a huge topic to discuss, which is it's something I'm actually working on now in mental health, which is the empathy and AI. Can AI provide empathy? Can they take the human empathy? Can they do it for us? The problem to answer that question is I don't agree that we will not need humans. I never ever imagine a scenario that we're only working with AI, no humans. But in that specific scenario, we need to be realistic. To be realistic, the nurses are overwhelmed, they're tired, they have a lot of things to do during the day to stay there and watch the patients. Like they work, they have actual work to do, forms to fill, they feed them the medication, any problems happening in the unit. They don't have time to just sit there and observe the patient when they are sad. That only works if you're hiring a specific nurse for each patient. And by the way, that's what we did. In the first study, what we did that we asked the nurses to write down the agitation events. We asked them, like, you're in the unit, you're already there, you see what's happening, please write it down. And after 2 weeks, we got nothing. Nothing. They didn't record anything. And when we asked them why, they were like, we're overwhelmed, we're working, we don't have time to sit and observe what's happening and write it down. And that's why we found a solution to hire a specific nurse, paying them just to sit there and see what's happening in the room. So I feel with AI, I want to think about it as I want to fit AI in a place that us humans not able to do that. Like the nurse job is not to sit there and observe. She helps. She helps with the agitation events. She helps to handle the situation. But to tell her to check or him to check what's happening before, that means you're just sitting there doing nothing and just watching them, which is not the scenario. So I usually think about AI that I need to put AI in a place when I have a problem. In our case, the nurses were clear with us, we can do this. We have other things to do. We're not going to sit there and observe what's happening. And if AI can help with that, I think that's going to be a great use of AI since at the end, we need to help humans to help humans. This is the ultimate goal here. So if we're helping humans, I feel AI is fitting perfectly in that scenario.
Thank you. And thank you for your question, Tim. Thank you for your concise answer there, Abeer. That concludes our session. I'll hand back to Sam, but thank you all for attending.
Nothing else from me. Thank you so much, Abeer. That was really very interesting. And yes, our next webinar is on the 10th of December. Adelina, you look like you want to say something.
I wanted to say thank you. That was fascinating, and we'll be following your work. Thank you.
Thank you.
Everyone.